Welcome to this explainer. We're diving straight into a high-yield clinical review of testicular pathologies and diagnostics. We've got a continuous stream of clinical cases and multiple choice questions to decode these complex pathways together.
So we'll be tackling four main areas today. First, diagnosing tumors, then managing undescended testes, moving on to identifying retractile testes, and finally, we'll wrap up with acute surgical emergencies. Let's get right to it.
Section 1. Diagnosing testicular tumors.
All right, consider this presentation. A 30-year-old male comes in with a painless, hard testicular mass right after some minor trauma. The mass is totally inseparable from the testis itself, and it doesn't transilluminate. So, what's the diagnosis here? Well, you might be wondering if the trauma actually caused it. Actually, no. Minor trauma is a classic red herring. It usually just causes local inflammation or prompts a self-exam, which is when the patient finally notices the lump.
The correct diagnosis is a testicular tumor, and the really critical exam pearl to remember here is about transillumination. Unlike fluid-filled hydrocells or spermatocells, which light up brightly like a light bulb, solid tumors never transilluminate. Another absolute hallmark, the complete loss of normal testicular sensation. That deep, dull ache you'd normally expect on a physical exam, it's completely gone. Now, to really understand this, we need to talk lymphatic drainage. The testes drains directly into the retroperitoneal para-aortic lymph nodes, way up at the L1, L2 level. It literally bypasses the groin completely. This means an early-stage tumor won't give you swollen lymph nodes in the groin. Instead, a palpable abdominal swelling right above the umbilicus might actually be your very first sign of bulky para-aortic metastasis.
This anatomical quirk dictates the incredibly strict protocol we have to follow when a mass is suspected. Start with a high-resolution scrotal ultrasound, which has near 100% sensitivity for confirming a solid mass. Next, you absolutely must draw serum tumor markers, like beta-HCG and alpha-theta protein, before doing any surgery. And let me be crystal clear here. Transscrotal needle biopsies are absolutely forbidden. If you puncture the scrotum, you risk spilling tumor cells right into the scrotal wall, which dangerously redirects the lymphatic drainage into those inguinal nodes we just talked about.
Once the mass is confirmed and a radical inguinal orchiectomy is performed, we move on to staging using the TNMS system. The gold standard for structural staging is a contrast-enhanced CT scan of the chest, abdomen, and pelvis. This completes our TNMS criteria, letting us evaluate the nodes and check for any distant visceral metastases, especially up in the pulmonary parenchyma.
Okay, moving on to Section 2, managing undescended testicles.
Let's shift gears to a pediatric case. A 4-year-old child presents with an impalpable right testis and an underdeveloped hemiscrotum. When dealing with an impalpable testis, a diagnostic laparoscopy is your gold standard. But if the surgeon is looking into the intra-abdominal space and spots blind-ending gonadal vessels, what's the next best step? The correct move here is to terminate the procedure immediately. Why? Because those blind-ending vessels definitively prove monochilia, which is the congenital absence of the testis, likely from a vascular accident while still in the womb. There is simply no viable tissue left to salvage, so you stop right there.
Now, what if both sides are affected? Let's say you have an 8-month-old infant with no palpable testes in the scrotal sac bilaterally. Bilateral cases demand a very unique approach compared to a unilateral impalpable testis. So how do we intervene to make sure everything develops properly?
Well, our initial game plan is a 1-month trial of HCG hormonal therapy. This is highly beneficial because HCG stimulates vascularity, weight, and testosterone production, which can actually induce natural descent. But if that fails, urgent surgical orchidopexy is required, ideally between 6 to 12 months of age. You really don't want to delay this past 1 to 2 years, because doing so accelerates permanent germ cell depletion and bumps up the risk of future testicular cancer, specifically seminomas, by a staggering 5 to 10 times.
Moving right along to Section 3, identifying retractile testicles.
Parents are often extremely alarmed by this next scenario. An 8-year-old's right testis occasionally goes in and out of a normal, well-developed scrotum. It vanishes, then reappears. It can be easily milked down and stays there without snapping right back. So, what's our best strategy here? Notice the critical detail. The scrotum itself is perfectly normal and well-developed.
The milk test is our key differentiator here, perfectly separating a retractile testis from a true undescended one. With a retractile testis, you're just looking at a hyperactive cremasteric reflex,
The sac is well developed, and you can gently milk the testis down where it stays temporarily. In contrast, a true undescended testis features a flat, hypoplastic scrotum, and you physically cannot force the testis into the base of that sac.
Because the anatomy in a retractile testis is totally normal, the management is incredibly straightforward. Clinical observation only. Zero surgical or hormonal intervention is needed. You can reassure the parents that as the boy goes through puberty, that cremasteric reflex will naturally calm down, and the testis was stabilized permanently right there in the scrotal sac.
All right, Section 4, Trauma and Acute Emergencies.
Let's turn up the heat with an ER presentation. Following a motorcycle crash, a young male has both testes completely absent from a previously normal, well-developed scrotal sac. He explicitly denies any history of cryptorchidism. This means the high-energy trauma actually displaced perfectly normal anatomy. What's our next diagnostic step?
This intense situation is known as traumatic dislocation of the testes, or TDT. The blunt impact basically ruptures the containment fascia, forcing the testicles retrograde, often shooting them into the superficial inguinal pouch or the pubic region. Your go-to diagnostic test here is a high-resolution color Doppler ultrasound. Not only does it locate the ectopic gonads, but crucially, it confirms if they still have healthy blood perfusion or if there's been a traumatic vascular occlusion.
Our next scenario is an absolute textbook emergency. A 19-year-old presents with sudden, agonizing unilateral testicular pain radiating straight to the abdomen. The testis is high-riding, lying horizontally, and has a negative Pren sign. Remember, a negative Pren sign means that manually lifting the scrotum doesn't relieve the pain at all. It actively makes it worse. So how do we manage this?
That presentation screams acute testicular torsion. And here's the terrifying part. Irreversible ischemic necrosis of the germ cells begins within just 6 hours of the cord twisting. 6 hours! That timeline makes this an absolute surgical emergency. You absolutely do not waste precious time on diagnostic imaging if it's going to delay care. You take them straight to the operating room.
The surgical protocol for acute torsion is strictly defined. Immediate scrotal exploration. If the tissue is still viable, you untwist the cord and perform a 3-point fixation, known as an orchidopexy. If the tissue is infarcted and dead, you have to do a radical orchiectomy. And here is a mandatory golden rule. Because the predisposing bell clapper deformity is almost always bilateral, you absolutely must surgically explore and fix the healthy contralateral side during that exact same operation. You have to prevent it from ever twisting in the future.
So, we've covered a lot of vital ground today. The real question is, could you quickly recognize these definitive surgical emergencies in a fast-paced clinical setting before the window for viable tissue completely closes? Keep these structured pathways fresh in your mind to decode these severe pathologies in real time. Thanks for joining this explainer, and I'll catch you next time.